Now, today we'll be talking about a very interesting topic, that is convulsion or seizure versus syncope. So, seizure versus syncope is a very common problem clinically. In both the cases, there will be loss of consciousness. So, how do we define seizure? It is an abnormal, excessive, synchronous electrical discharges from the brain, which is actually a seizure. Whereas in syncope, it is transient loss of consciousness due to global hypoperfusion of the brain. So there is usually hypoperfusion in the syncope for few seconds, from 5 seconds to 10 seconds, whereas there is an abnormal excessive electrical discharges from the brain, which is seizure. So it is basically caused by reduced blood flow, whereas this is an electrical phenomenon. So seizure almost always lasts for around 20 to 30 minutes. So patient may have this convulsions or seizure activity which may last for 4 to 5 minutes or 6 minutes, maybe 10 minutes. But after that, patients usually have post-ictal confusion, a confusional state which may last for around 10 minutes, 15 minutes, depending on severity of the seizure. Whereas syncope is very almost always for few seconds only, maybe hardly 10 seconds or 15 seconds or 20 seconds. Usually it is never more than 2 minutes to 5 minutes. So, usually syncope is precipitated by stress or valsalva or pressure over the neck or unpleasant sight. These precipitates syncope. Abnormal neck posturing or abnormal neck movement, or intensively coughing, which puts pressure on the neck, very commonly puts pressure on the carotids, and that is what it may cause syncope as well. Whereas for seizure, usually it is lack of sleep which can cause this type of convulsions or seizure. The dehydration, prolonged standing, these also can very commonly precipitate syncope, which is not caused in actually seizure. Tongue bite is extremely important finding. Wherever tongue bite is there, usually it is almost always seizure, whereas this is very uncommon in patients with syncope. Passage of urine or feces is not very common in seizure, but wherever it is present, it is almost always considered as seizure only, whereas this is very uncommon in syncope. As this seizure is electrical activity, there is huge electrical discharges from the brain. Usually, headache can be very commonly accompanied after this seizure, whereas this is not usually seen with syncope. In syncope, as I told, there is loss of consciousness for few seconds. So these patients usually regain consciousness very easily within a period of in a minute. In a minute, they are conscious, wide awake, they know everything. Whereas post seizure, patient may have post-ictal confusion, which may last for 20 minutes, 30 minutes, hours also. It may last for 1 hour, 2 hour, or 3 hours also. Or patient may be in confusional state for a few hours also in seizure, whereas this is not the scenario in syncope. Generalized tonic-clonic seizures is extremely common in seizure patients, whereas this GTCS is not very uncommon in syncope. It can happen, but it is very uncommon. So for seizures, what do we do? We definitely do MRI brainwave stroke protocol with VST. VST we do for venous sinus thrombosis. Actually, this can be seen as an infarct on MRI brain, and if it is VST, this headache plus convulsion is usually the combination, which almost very commonly is seen with uh, venous sinus thrombosis. Whereas for syncope, we usually evaluate it by blood pressure, ECG, 2D echo, 24-hour Holter monitoring. We look for hypotension or drug-induced hypotension, or we usually look for arrhythmias. Or by echo, we can see whether patient has heart failure with reduced ejection fraction. So here we evaluate for usually heart, whereas we evaluate by MRI or EEG, which shows the electrical problem. So in patients with syncope seizure, arrhythmia is very, very less common or very uncommon, whereas the patients presenting with syncope, they may very highly likely to have arrhythmia. Whenever patients of seizure present, the blood prolactin levels definitely may be increased, whereas this prolactin or CPK, there is no reason why they should increase in syncope. So they are not increased in the blood in syncope, whereas in seizure, the serum prolactin increases. And if it is present with GTCS, that is generalized tonic-clonic activity of the muscles, then serum CPK, creatinine phosphokinase, which is present in the muscles, can definitely increase. So this postictal altered sensorium is extremely common in seizure patients, whereas it is very uncommon in syncope patients. This seizure syncope very commonly occurs in almost always in standing or sitting posture only, whereas seizure has no posture. It can occur at any point of time, anywhere, in any posture. And before syncope, if it is heart related, arrhythmia related, then palpitations, lightheadedness, sweating can be very much common. Whereas this type of symptom, these symptoms of palpitations, lightheadedness, they are very uncommon in seizures. But the aura is very common in seizure. Aura means before getting seizure, patient may have a different type of headache or uneasiness, and they may it may be followed by a convulsion episode or seizure episode, and this may be repeated every time. So patients usually understand that they may get seizure. So this aura is not found in all the patients. Maybe around 20% patients of all the seizure patients may have such typical aura, which may not be seen in each and every patient. So these are all the points which discusses between seizure versus syncope. Thank you.